Oxytocins. Okay, we have left from oxytocin. Oxytocin it can in use active management of the stage of labor. 10 units intermuscular at delivery of anterior soldier within 1 minute of delivery of the baby, and you can add 5 ml in over 5 seconds. 10 unit IV 500 ml IV infusion. Side effect: hyponatremia, water intake section, hypertension, neonatal hyperbilirubinemia. Monitoring uterine contraction 3 to 4 contraction in 10 minutes lasting for 45 to 60 seconds. 200 Montevideo units. Fetal heart rate CTG has to be monitored. Methogen used in third stage after complete delivery because it closes the cervix. Used to prevent control postpartum hemorrhage to speed expulsion of the placenta. Dose 0.2 mg IM. Start repeat after 15 minutes, thereafter 4 hourly, maximum 5 doses. IV is 95 seconds, IM is 7 minutes, oral is 10 minutes. Action. Methogen side effect is hypertension, seizures, nausea, vomiting, coronary arterial vasoconstriction, pulmonary hypertension. Contraindication: deep vein thrombosis patients, asthma patients, you can't give methogen. Hypertension, cardiac disease, you have to avoid methogen. Caropos PPS management 250 microgram IM, maximum 8 doses can be given every 15 to 90 minute interval, can be given by intramyometal. Increase pulmonary vascular resistance, contraindicated in pulmonary arterial hypertension and asthma patient. Misoprostol PGU1, medical abortion 200 microgram, repeat 12th hourly. Cervical rifling prior to uterine procedures. Induction of labor 25 to 50 microgram misoprostol has to be given vaginally every 4 hourly or 6 hourly. Histoscopy to dilatation and dilatation evacuation. Atomic PPS 600 to 1000 microgram rectally. Medical abortion, rifling, induction of labor prior to procedure like histoscopy, cervical rifling prior to procedure, histoscopy, dilatation evacuations. Nausea, vomiting and severing, diarrhea, chills and diarrhea, nausea, vomiting, severing and uterine tachycystole, meconium and amniotic fluid. The PPS South for Malaysia told. Then tranexamic antifibrinolytic, load stabilizer, adrenaline inhibit conversion of plasminogen to plasmin, hence prevent breakdown of clot. Plasminogen to tranexamic acid inhibit plasminogen activator, inhibit the tissue plasminogen activator, inhibit the tissue plasminogen activator so that it can convert to plasminogen to plasmin. Plasmin can convert fibrin to fibrin degradation product. Okay, increase collagen synthesis which preserve the fibrin matrix and increase the tensile strength of the clot. Fibrinolysis. Tranexamic acid, women trial effect early tranexamic acid administered on mortality, hysterectomy, other morbidity in women with postpartum hemorrhage, and international randomized double-blind placebo-controlled trial. Women with diagnosed PPS enrolled here 193 hospital in 21 countries. There is significant decrease in the death due to bleeding. Hysterectomy rate did not changes. Death from all causes did not decrease. No increase in the adverse outcome with tranexamic acid. Tranexamic acid can be used by PPS 1 gram IV within 3 hours of delivery. If continue bleeding, administer second dose within 24 hours. Dose not exceed 2 gram per 24 hours. Risk of renal cortical necrosis and seizure disorder. Renal cortical. Other uses to prevent reduced blood loss, abnormal uterine bleedings, heavy menstrual bleeding during after abdominal surgery, vaginal surgery. During or after abdominal vessel, dose 1 to 1.5 gram or 15 to 25 mg per kg 2 to 4 times daily. Adjustment dose is renal impairment. Antihypertensive, labetalol, nifedipine, alpha-methyl dopa. The labetalol injections, BP monitoring 2 to 4 ml. This injection slow bait, labetalol mechanism alpha and beta blocker, non-selective, fast-line drug of gestational hypertension, rapid onset 1 to 2 minutes. Dose in gestational hypertension 100 to 200 mg BD or TID, maximum dose 1200 mg per day. Hypertension emergency 20 40 80 80 every 20 minutes, maximum 220 mg per cycles. Side effect is fetal bradycardia and FGR, fetal growth restrictions. Contraindication of labetalol is reactive air disease, bradycardia and heart blocks patients, pulmonary edema patients. Labetalol is contraindicated heart blocks, pulmonary edema, because it is a beta blocker. So in heart blocks you should not give. Pulmonary edema you should not give. Brady, already if there is brady you should not give. Bradycardia already it causes SA node blocking. Beta blocker, so reactive air disease, bradycardia, heart blocks and pulmonary edema. Okay, nifedipine mechanism actions: calcium channel blocker, smooth muscle relaxants, metabolism in liver, excretion in the kidney. Side effect is hypotension, tachycardia, reflex tachycardia, headache, and contraindication is heart failure patients that reduce ejection fractions. Heart failure reduce ejection fractions. Okay, warning don't use sublingually because it's exaggerated BP Paul. Nifedipine is antihypertensive. One uses antihypertensive, another uses tocolytic. For anti-AD, this is the second line, 10 to 20 mg every 4 hourly or 8 hourly, maximum 120 mg per day. Okay, so 4 hourly means 6 doses, nifedipine 6 or Q 4 doses, 6 hourly, 3 doses. Okay, rapid onset action every 5 to 10 minutes. First line of drug of choice is tocolysis. If you tocolysis, first line 30 mg oral start, 30 mg start, then 20 mg QID or TDS for till steroid coverage. Tocolysis 30 mg for 20 mg. Indomethacin, prostaglandin synthesis inhibitor, non-specific cyclooxygenase, 50 mg orally start followed by 25 mg 6 4 hourly 40 hours. Caution to be closer of doctor strategies. Beyond 32 increase capital renal function impairment, contraindicated dysfunction, liver, gastric ulcer, bronchiasthma. Duvadilon, isosoxpurin, beta adenine receptor agonist. Can you use when nifedipine? The side effect of isoxazoline is duvadilon. You have to start with can be used when nifedipine is not effective. The dose is 40 mg in 500 ml NS till contraction ceases. 40 mg in 500 ml, or when heart rate is 120 per minute followed by 10 mg 8 or tachycardia, hypertension, tremor, hyperlipidemia, hyperkalemia, hyperglycemia, myocardial ischemia. The contraindication is cardiac disease, thyroid disease, severe anemia. Other beta mimetic ritodrine is withdrawn. Torbutalin is 0.25 mg subcutaneous or 0.5 mg orally 6 hourly. In tachysystole, you have to give 0.25 mg subcutaneously or oral dose is 0.5 mg every 6 hourly. 4 doses. Tocolytic before ECB. You can give tachysystole patients this beta mimetic torbutalin tachysystole patients, or you can give tocolysis before external cephalic version, that is torbutalin. Atosiban is the oxytocin receptor antagonist. Initial dose is 6.75 mg. This was isoxazoline is 40 mg. Atosiban is 6.75 mg. IV maintenance, no not a drawback. Magnesium sulfate reduce presynaptic release of neurotransmitter glutamate, blockade NMD receptor, potential potentiation of adenosine actions, improve calcium buffering by mitochondria, blockage of calcium entry by voltage gated calcium channel. So very important question they will ask in the short notes. Mechanism action of magnesium sulfate, it will reduce presynaptic release of the neurotransmitter glutamate. Then it blocked the glutamate receptor, NMD receptor. It prevent the release. It blocked the NMD receptor, glutamate receptor, potentiations, adenosine actions, improve calcium buffering by mitochondria, and blockade the calcium gated voltage gated channels, calcium entry. Therapeutic range is 4 to 7 millicurie per ml. Contraindication is renal failure, myasthenia gravis, myocardial ischemia or failure. Magnesium sulfate uses cerebral palsy, prophylactic preterm labor. We can give prevention of recommended dose, tocolysis and no prophylaxis. Loading dose is 4 gram, then 2 grams, 1 gram per hour up to 24 hours. Uses eclampsia, you can give anticonvulsant. Jusman regimen, you can give. Loading dose is 4 gram IV 100 ml over 15 to 20 minutes, followed by 1 to 2 gram per hour infusions has to be started. Then is 4 gram IV bolus, 10 gram IM, 5 gram each buttocks. Then maintenance dose 5 gram 50% serotonin buttock has to be given. This is the recommended sulfate dosing schedule, seizure prophylaxis, loading dose, then maintenance dose, continuous IV infusions. Magnesium sulfate monitoring rate more than 16 Nichox, more than 25 ml per hour. The normal range milliequivalent 4 to 7, it is 2 to 3.5, 4.8 to 8.5. Loss of patellar reflex, more than 2 respiratory arrest, more than 12. Anticonvulsive purposes. Antidote is calcium gluconate 10 ml, 10% over 10 minutes. Anticholinergic steroid, betamethasone, dexamethasone, 12 mg, 2 doses, 24 hour effect, 6 mg and 4 days, 12. Single course of recommended 24 to 34 days for pregnant who are risk of delivery within 7 days, SUG 7.1. The repeat dose is not recommended, but single rescue dose can be given women whose initial course of ANC was given at less than 28 weeks of gestation or more than 14 days prior and expecting delivery within next 7 days. 14 days prior, rescue dose can be given more than 2 weeks. Okay, or and expecting delivery within next 7 days. Anticonvulsive steroid administration increase fetal lung maturity, decrease in situ severity like respiratory distress syndrome, intraventricular hemorrhage, HI, necrotizing enterocolitis, systemic infections, mortality. The respiratory distress syndrome, intraventricular hemorrhage, necrotizing enterocolitis, systemic infections, mortality in the first 4 hours of life. The clomiphene citrate is a mechanism of action is selective estrogen receptor modulator. Occupy estrogen receptor in the hypothalamus. Estrogen is unable to bind to the receptor, thereby FSS will increases estrogenic effect on the ovulations and anti-estrogenic effect on the endometrium and the cervix. So dose is 50 to 100 microgram per day to day 6. Maximum dose is 250 microgram per day. The resistance, no ovulations despite giving of clomiphene for 6 months. If after giving 6 month treatment, 6 cycle, no ovulations, this is called as clomiphene resistance. Failure means very important, 2 terms you have to remember: resistance and failure. If no pregnancy, it is failure despite ovulations, despite giving clomiphene 6 months. Remember very important things. Two different terms. One is resistance, mean if you giving continuously for 6 months, after that also there is no ovulation with clomiphene citrate after a maximum dose of 250 microgram per day, then it is called a clomiphene resistance. If a failure, when you will call no pregnancy after evidence of ovulation after giving a clomiphene citrate despite giving for a 6 month. Okay, clomiphene citrate incidence is ovulation chances is 80% and pregnancy chances 40%. Remember 80 by 40. Remember clomiphene, always remember clomiphene name आएगा तो CC 80 by 40. 80 is ovulation, 40 is pregnancy rate, multiple pregnancy. 80, 45. Remember, very important. 80, 45, 5, 8, 40. Okay. The uses in female is anovulatory infertility, polycystic ovarian disease, oocyte harvesting before IVF cycles. In male, you can give for oligospermia. Okay. The clomiphene citrate contraindication: ovarian cyst or tumors, ovarian failures, hepatic dysfunctions patients. Okay. The letrozole mechanism actions is aromatase inhibitor, decrease peripheral conversion of the estrogen. The dose is 2.5 to 5 mg per day, day 3 to day 7, or as a single dose 10 to 30 mg on day 3. Advantage of letrozole over clomiphene citrate: it is cause monofollicular development, no anti-estrogen effect on the endometrium, no preterm pregnancy rate. Okay. So leuprolide acetate, GNS analog, activate GNS receptor, increase FSS and less secretion. Initial stimulations, player response followed by sustained drop in gonadotropin secretion due to desensitization and down regulations. Very important terms you have to tell in exam. Uses of leuprolide acetate in IVF cycle: prevent premature luteinizations, synchronize the follicular recruitment, control ovarian hyperstimulation syndrome, prevent करता है. Ovulation trigger के लिए you can give a leuprolide acetate. Male infertility you can due to hypothalamic hypogonadotropin hypogonadism, you can give a leuprolide acetate. Uterine fibroid and endometriosis, the 3.75 mg monthly, total monthly per 3 months, or 11.25 mg 3 monthly dose for 3 to 6 months. The reduced fibroid size and vascularity, decrease estrogen and progesterone concentration by ovulation inhibitions. Recruitment of ovarian sex steroids, recurrent ovarian sex cord stromal tumor you can give. So very important, the leuprolide acetate. Leuprolide acetate you can give an IVF cycle to prevent premature luteinizations and synchronize the synchronize that will cause prevent premature luteinizations and synchronization of follicular recruitment and control over and prevent control OHS. Ovulation trigger you can use male infertility, hypothalamic hypogonadotrophy, hypogonadism. It can use uterine fibroid endometriosis, and it's reduced fibroid size and vascularity, decreases estrogen and progesterone by control ovulations, inhibitions. Recurrent ovarian sex cord stromal tumor you can give. Leuprol acetate GNS protocols, already I told, it is used to prevent premature leuterization. The side effect: hot flashes, nausea, vomiting, headache, dizziness, taste in mouth, increased bone pain, diarrhea, local reaction, or irritable vaginal bleeding, polyuria, polydipsia. HMG gonadotropin, human menopausal gonadotropins, commercially excreted for the postmenopausal urine. 75 LHFSS ratio. Mechanism: monofollicular maturation and ovulations, adverse effect: fever, ovarian hyperstimulation, multiple pregnancy. HMG high dose step down protocol and low dose protocol, chronic low dose protocol. Okay, very important, the high dose step down protocol. What is step down? Starting dose, you have to give a high dose. Okay, suppose you are giving 112.5 to 187.5 monofollicular FSH. Then you scan on day 4 to day 5, follicle size more than 9 mm to 10 mm. So then you have to decrease by 37.5 and scan on day 8. Again you do scan every day, decrease by 37 every doing scan. Then when the follicle size is more than 16 mm, you give SCZ dominant follicle 5000. Low dose protocol, you have to start with 37.5 to 75. Step down on low dose protocol. Step here you have to increase the dose 37, increase 50% or 37.5 on day 7, day 7, 14, 21. Again the same thing, SCG will give once it is more than 16 mm, increase 100%. Gradually 50% increase dose, 100% increase on day, you have to increase the dose on the day 14, 50%, 21, 100%. Chronic low dose protocols, in starting dose 37.75, scan on day 7, day 14 you will increase 50%, day 20 into 15%, follicle is 14 mm, decrease dose by 15%. Then HCG one more thing, FSS threshold dose decrease 50% when leading follicle is 14 mm. So here I have to in between, when it is size follicle size is 14 mm, so you have to decrease the dose 15%. Okay, bromocriptine synthetic ergot derivate, mechanism asteron, potent D2 agonist actions. It uses hyperprolactinemia and lactation suppressions. 2.5 to 10 mg per day. Side effect: nausea, vomiting, postural hypertension, behavioral alteration, libido reticularis, contraindicated pregnancy. Cabergoline dopamine receptor agonist, hyperprolactinemia 0.25 mg to 1 mg twice weekly or 0.5 to 2 mg once weekly. Ovarian hyperstimulations use करते हैं 0.5 mg OD for 8 days. Then suppression of lactation 0.5 start doses. Advantage: safe in pregnancy, side effects similar to bone but lesser. Anti-immunoglobulin to prevent Rh isolation. Rogan is a polyclonal product from human plasma. Root is DPIM, 2 to 4 days half-life, 24 days is high-pay. Protection 300 micron provide 12 weeks protection against exposure to 330 ml blood, and 15 ml RBC. Routine routine antenatal anti-prophylaxis, anti-D 1 gram 300 micrograms should be given routinely. All RS negative non-sensitized women at 28 weeks gestation when fetal blood is known or known to be RH positive. Anti-D hemoglobin first trimester 15 to 100 micro anti-D is given as soon after a sensitizing event like significant bleeding from the during threatened abortion, spontaneous miscarriage, MTP, surgical termination of pregnancy, ectopic pregnancy, vesicular parcel or chronic biopsy, embryonal reductions. In second, third trimester, at least this is 50 to 100 microgram in first trimester. In second trimester, at least 300 microgram, 10 microgram additionally anti-D every additional 0.5 ml fetal RBC in maternal circulation. 300 star dose, then every event 0.5 ml fetal RBC in maternal circulation. Then you have to add 10 microgram each. Amniocentesis, abruption, placenta, blonde trauma, intrauterine fetal death, external cephalic bursons, placenta previa with bleeding. Okay. The postpartum prophylaxis 300 micron IM or IV should be given within 72 hour delivery to postpartum non-sensitive negative delivery as possible payment. Additional anti-D IG may be required for preternatal hemorrhage greater than 50 ml. If it is greater than 50 ml blood, RBC or 30 ml fetal blood. HPV vaccines, primary prevention, CS cervix, genital ward, duration 5 to 6 days, protection 10 years. Durations 0.0 to 6 months. 9 to 13 years girls boy. Catch-up vaccines 14 to 16. Best given before any sexual activity. Cervarix, Gardasil 9. Cervarix is 9 to 26. Gardasil 16, 18. How many doses? 3 doses, 0 to 6. Gardasil 9, 9 to 26 and 9 to 26 only. 6, 11 with causal genital cancer. HB वैक्सीन सर्विक्स बल्बा वजाइना पेनिस anal canal सर्विक्स बल्बा वजाइना होगा पेनिस होगा anal canal और ओपनिंग्स clindamycin को द ट्रीटमेंट ऑफ बैक्टीरियल वेजिनेसिस कैंडिडियल वेजिनेसिस बैक्टीरियल वेजिनेसिस clindamycin 100 mg intravaginal at bedtime for 3 days 300 mg orally 2 HDD for 7 days 2% cream or 5% intravaginal at bedtime for 7 days candidial vaginitis clotrimazole 200 mg intravaginally at bedtime 3 days 1% clotrimazole cream intravaginally 14 days. This is all kit A1 it contain azithromycin and cefixime. It is for urethral cervical anorectal distress. It is grey color. Green color kit 2 secnitazole 2 gram fluconazole 150 mg start dose. Vaginal distress vaginitis genital ulcer non-herpetic kit 3 is white benzathine penicillin 2.5 milli internal 1 by azithromycin 1 gram kit also contain 10 ml disposable serum 21 gauge needle 1 by vial 10 ml distilled water. Genital ulcer non-herpetic patient allergic to penicillin kit for blue. Kit 3 is white, kit 4 is blue, doxycycline for 14 days, 100 mg BD, azithromycin 1 gram 1 tablet, non-herpetic. So, genital ulcer herpetic, kit 5 is red, aceclipine 400 mg TDS for 7 days. Lower abdominal pelvic inflammatory disease, kit 6, cefixime 400 days start, metronidazole 400 BD 14 days, doxy for 14 days, inguinal bubo black, doxy 100 mg 21 days, azithromycin 1 gram. Okay, let's